Okay, let's dive right into this explainer. We're going to unravel a topic that is just universally misunderstood in medicine. Look, whether you're in the clinic, the ER, or the OR, hemorrhoidal disease is something you are going to encounter constantly, right? But so much of what we're taught is just based on outdated concepts. So today, we're breaking down the basic science, the anatomy, and the exact step-by-step clinical protocols you need to manage this with absolute confidence. We start with a mystery. Picture this. A 50-year-old executive rushes into your clinic and he is absolutely terrified. He tells you he saw bright red blood pooling in the toilet bowl, he felt a mass prolapse out, and he is sitting on your exam table fearing the absolute worst. He's thinking anal cancer. You perform an anoscopy and you find these large vascular masses at very specific points in the anal canal. So, how do you explain what's actually happening to him? And, more importantly, how do you fix it? Well, here's our roadmap to take you from that clinical mystery to absolute mastery. 1. The hemorrhoid misconception. 2. Anatomy and pathophysiology. 3. Internal versus external hemorrhoids. 4. Step-by-step treatment options. And 5. Golden clinical bedside pearls. Let's jump into Section 1, the hemorrhoid misconception, relearning the basic science and dismantling the myths. We need to drop a radical truth here that completely flips how we view this disease. Read this quote. Hemorrhoids are not varicose veins of the anus. This is a myth still taught to medical students everywhere, but it's just wrong. They are essential, normal, anatomical structures present in every human being from birth. The problem isn't that they exist. They're just normal vascular cushions. The actual disease state only starts when they suffer a sliding prolapse. Far from being a disease, these specialized vascular spaces, made up of arteriovenous communications, tritus muscle, and connective tissue, actually give us about 15 to 20% of our resting anal continence. They act exactly like the soft rubber weather stripping on a front door. When the sphincters contract, this fluid-filled cushion creates gas-tight seal, filling all those tiny microgaps to ensure perfect continence, no leaks. We only call it hemorrhoidal disease when those cushions get symptomatic, engorged, bleeding, or prolapsing. Moving right along to Section 2, Anatomy and Pathophysiology, mapping the mechanical breakdown of the anal canal. When you're doing an exam, you are looking for masses at highly specific clock face positions. Why there? Well, because they're driven directly by the terminal branches of the superior rectal artery. You're going to find them at 3 o'clock, which is left lateral, 7 o'clock, right posterior, and 11 o'clock, right anterior. So when that executive is on your table, those are the exact coordinates where you're going to find the engorged cushions. The disease happens through a precise pathological domino effect. It starts with straining, which causes congestion in the corpus cavernosum recti. Over time, that chronic congestion stretches out Treats muscle and Park's ligament. Think back to our weather stripping analogy. These muscles and ligaments are like the tiny screws holding that rubber seal to the door frame. When the screws rot and break down, the rubber just sags. It loses support, slides down, gets caught in the doorway, jams, and eventually bleeds. That slide, that is the true definition of hemorrhoidal disease. All right, Section 3, internal versus external hemorrhoids, navigating the clinical danger zone. This brings us to the most dangerous, high-stakes part of this explainer, answering a literal life or death board question. On the left, we have internal hemorrhoids, located above the dentate line. Because this area uses visceral innervation, you can safely band or inject them right in the office, no sharp pain. But look on the right, external hemorrhoids, below the dentate line. This area is packed with somatic pain fibers. If you make the mistake of banding or injecting below the dentate line, you will plunge your patient into excruciating, unyielding agony. Like, you can literally cause neurogenic shock, no joke. Hey, before we move on to how we safely treat this, take a quick second to hit like and share this explainer with a colleague. By making sure they understand this strict anatomical boundary, you might literally save them from a massive clinical disaster and save a patient from unimaginable pain. Seriously, it's that important. Okay, let's jump into Section 4, step-by-step treatment options. From office procedures to surgical interventions. With the anatomy mapped out, our entire treatment logic rests on Goligher's Classification. It's a clinical staging system that dictates our step-by-step algorithm. But, and this is a big but, pay close attention here. This classification applies only to internal hemorrhoids. It's all based on how much that internal tissue is prolapsing. For early grades, rubber band ligation, or RBL, is the in-office gold standard. And that's not just an opinion. It was proven superior to sclerotherapy in the landmark 1995 McRae meta-analysis. But you need absolute discipline here. The band absolutely must be applied 1 to 2 centimeters proximal to the dentate line. Do it right, and the band strangles the tissue, causing ischemic necrosis. In about 5 to 7 days, it sloughs off, fixing the mucosa to the underlying muscle. It's essentially like putting a new screw into our weather stripping to hold it back up. But what if office treatments fail? Or what if our executive comes in with severe grade 4 prolapse? That's when we step up to advanced surgical interventions. Excisional hemorrhoidectomy, like the Milligan, Morgan, or Ferguson, remains the gold standard for grade 4 or mixed components. For patients really worried about pain, we have alternatives. There's stapled hemorrhoidopexy, or PPH, which avoids anoderm incisions altogether, or Doppler-guided THD, which ligates specific arteries to shrink the tissue with way less post-op pain. It's fascinating to see how major bodies approach this. Check out this table. The ASCRS pushes diet modifications and RBL for first-line grade 1 and 2, and they firmly back excisional hemorrhoidectomy as the gold standard for grade 4. On the flip side, the European Society of Coloproctology, the ESCP, lists RBL or injection sclerotherapy for early stages, but they actually recommend Doppler-guided THD as a lower pain alternative for refractory cases. It really shows the nuance between prioritizing complete excision versus minimizing post-op pain. Finally, Section 5, Golden Clinical Bedside Pearls, Essential Rules for the Clinic and Operating Room. Let's wrap up with some practical wisdom. 72. That number is your critical window. If a patient presents with an acutely painful thrombosed external hemorrhoid within 72 hours, excise it in the office under local anesthesia. Immediate relief. But if it's past 72 hours, put the scalpel away. Seriously, just use stool softeners. The pain has already peaked, and cutting now just creates a painful wound for absolutely no reason. And when you do operate, here is a massive warning. Never be over-aggressive. Always preserve mucosal skin bridges between excisions. If you strip away too much tissue, you'll cause severe, irreversible cloacal deformity. Anal stenosis is a nightmare. Remember, you're just trying to fix the weather stripping, not rip out the entire door frame. I'll leave you with this final thought. We've totally dismantled the varicose vein myth today. Knowing now that hemorrhoids are essential, normal structures vital for continence, how will respecting the body's natural weather stripping fundamentally change the way you adapt your proctology practice tomorrow? Keep those mechanics in mind on your next shift.